preeclampsia and combine it with a Doppler study. Thank you.
Thanks a lot, Dr. Sergani, for this proper research and your excellent presentation. The last talk with Dr. Mariam. Dr. Mariam.
Yes, the last talk. There's preeclampsia and endoglobulin by Dr. Mariam Samir from National Research Center.
Soluble endoglin as a new marker for prediction of preeclampsia in early pregnancy. Preeclampsia is a pregnancy-specific condition that increases maternal morbidity and mortality. It's a multi-system disorder characterized by abnormal vascular response to placenta. It is diagnosed by new onset, increased blood pressure, 140 or more systolic blood pressure, and or 90 or more diastolic blood pressure, and 24-hour proteinuria, 0.3 gram or more, 1+ in dipstick, after 20 weeks of gestation. It ranged from 3% to 7% of nulliparous and 1 to 3% of multiparous. Preeclampsia complicates 3 to 8% of pregnancies in Western countries, and overall 10 to 15% of maternal deaths are directly associated with preeclampsia and eclampsia. In Egypt, poor quality antenatal care contributed to 15% of maternal deaths. 34% of them are associated with hypertensive disorders, with an estimated 13 maternal deaths per 100,000 live births. The Ministry of Health and Population Survey showed that 13% of maternal mortality is due to hypertensive disease with pregnancy. Etiology is unclear, but some findings support the hypothesis of vascular-mediated factors, placental ischemia, genetic and immunological etiology. There are many risk factors of preeclampsia, includes antiphospholipid syndrome, renal disease, prior preeclampsia, systemic lupus erythematosus, nulliparity, chronic hypertension, diabetes mellitus, high attitude, multiple gestations, strong family history of cardiovascular disease, family history of preeclampsia in first-degree relative, advanced maternal age. Pathophysiology of preeclampsia. During normal pregnancy, the villus cytotrophoblast invades into the inner third of myometrium, and spiral arteries lose their endothelium and most of their muscle fibers, so it becomes slow sensitive or even insensitive to vasoconstrictive substances. This diagram shows comparison between the normal placentation and abnormal placentation. The abnormal placentation happens in preeclampsia with abnormal invasion of the trophoblast to the spiral arteries, with also oxidative stress of the placenta and chronic placental ischemia. All those lead to maternal abnormalities of maternal symptoms, and also endothelial destruction due to imbalance between the pro-angiogenic factors like vascular endothelial growth factor, which will decrease, and placental growth factor, with elevation of angiogenic factors like soluble endoglins and soluble FM tyrosine, like tyrosine 1. This imbalance will lead to endothelial destruction and clinical manifestation of the mother, include hypertension, injury of the kidneys, and decreased glomerular filtration rate with result in proteinuria, liver dysfunction, and HELLP syndrome, brain edema, and furthermore, maybe eclampsia and seizures, placental sufficiency and intrauterine growth restriction of the fetus, small for gestational age, oligohydramnios, perinatal deaths. This diagram shows also the multifactorial of the pathogenesis of the preeclampsia, which lead to hypertension and proteinuria, imbalance between the angiogenic factors and the immunological factors and contribution of genetic factors. Chronic placental ischemia causes fetal complication, as we said, and oxidative stress causing maternal complications. This diagram illustrates the complication in maternal and fetal. Management of preeclampsia. Maternal and fetal assessment prior to the management. Then according to the gestational weeks and the condition of the mother and fetus, whether if it is 37 weeks or more, they will go for delivery. If it is more than 34 weeks of gestation with severe preeclampsia or labor or rupture of membrane, abnormal fetal testing, severe oligohydramnios or fetal growth restriction, the option is delivery. If not, if it is mild cases below 37 weeks of pregnancy, hospitalization and maternal and fetal assessment, if worsen, labor, delivery is the option. In severe diseases less than 34 weeks, steroids, antihypertensive drugs, daily assessment of maternal and fetal condition, and delivery at 34 weeks. Screening at high risk and preventing recurrence are key issues in the management of preeclampsia. Biochemical markers that could predict the subsequent onset of preeclampsia before maternal clinical manifestation would be advantageous because they may indicate the pathophysiological mechanism of the disorder and identify specific patients early in pregnancy that are at high risk of developing preeclampsia. If the application of such simple tests is possible, they can be very useful, especially in developing countries. The objective of our study is to evaluate the use of new markers in the prediction of preeclampsia few months before the onset of manifestation. This longitudinal case control study included all pregnant women with previous history of pregnancy-induced hypertension attending antenatal care unit in prenatal diagnosis and fetal medicine department at National Research Center. Approval of ethics committee was obtained and all participants signed informed consent. Blood samples were taken between 14 and 18 weeks of gestation. Follow-up of these women was done till delivery. Those who complete their follow-up were enrolled in our study. A total of 66 single-term pregnant women between 18 and 35 years old were divided as follows: 15 pregnant women who developed gestational hypertension, 18 pregnant women who later developed preeclampsia, and 33 normostensive pregnant women as a control. All women were asked to know her last menstrual period and confirmed by ultrasonography done for all pregnant women as a part of routine follow-up and to determine gestational age. All women were subjected to full history intake, general examination, and blood pressure measurement. Gestational hypertension was considered in the elevation of blood pressure after 20 weeks gestation to 140 or more millimeter mercury systolic and or 90 millimeter mercury or more diastolic pressure. For preeclampsia, elevated blood pressure was accompanied with proteinuria measured by dipstick at least one positive 30 milligram per deciliter. Exclusion was done to twin pregnancies cases with fetal abnormalities, maternal renal disease, and connective tissue disease. 5 millimeter of blood samples were collected from pregnant females at 14 to 18 weeks gestation. The samples were collected on EDTA and centrifugated. Plasma was divided into adequate and frozen till time of the assay. Routine investigations were done in addition to plasma antigenic markers were assayed: vascular endothelial growth factor, placental growth factor, and soluble endoglins. All were quantified with enzyme-linked immunosorbent assay. This table shows the characteristics of studied group. Odd ratio was estimated to evaluate the risk of developing preeclampsia based on the calculated cutoff ratios. This table shows the median value of plasma vascular endothelial growth factor, plasma growth factor, and soluble endoglin in the three groups with the significant values. A statistically significant difference was found in comparing the median level of vascular endothelial growth factor and placental growth factor in cases of gestational hypertension and preeclampsia with controls. A statistically significant difference was found in comparing the median level of vascular endothelial growth factor in gestational hypertension group with preeclampsia. The median level of soluble endoglin had a statistically significant difference in comparing gestational hypertension and preeclampsia group with controls. A cutoff value of 31 picogram per milliliter of vascular endothelial growth factor yielding a sensitivity of 94.4%, specificity of 72.9%, with accuracy 78.8%. Placental growth factor at a cutoff level of 49 picogram per milliliter had a sensitivity of 77.8, specificity of 89.6%, with accuracy of 86.6%. In case of soluble endoglin, the sensitivity was 94.4%, specificity was 87.5%, and accuracy was 89.5%. This figure shows the correlation between the levels of vascular endothelial growth factor and placental growth factor in preeclampsia group. And this is soluble endoglins with placental growth factor, which shown